In this video segment, I'd like to discuss Fuchs endothelial dystrophy. This is a condition that affects a lining of cells within the cornea called the endothelium. Before we step into a deeper discussion of Fuchs itself, it's important to take a moment to highlight the anatomy of the cornea. The cornea is the clear window of the eye. It's the surface upon which one places a contact lens, if you're a contact lens wearer. The cornea itself is designed to be a clear tissue so that light can pass through and then get focused onto your retina and then sent as a signal over to your brain. In order to have crisp vision, the cornea itself must be compact and clear. It turns out the cornea is a multi-layered structure, and I like to make the analogy it's like a hardcover textbook. There's a top cover, a bottom cover, and all these pages in between. The top cover effectively is like the skin, much like the skin that covers your body, and it helps to protect the underlying tissue. All the pages of the book are actually called stroma, and it's tissue that's organized in a way that is compact and clear so that light can pass through. And then on the back cover, there's a layer of cells, a single layer of cells called endothelium. Those cells function to help pump fluid out of the cornea so that the books doesn't get swollen, so that the pages don't swell and the book increases in thickness. It's very important that these cells work, and because if they don't, the vision can get cloudy. As it turns out, every night when we close our eyes to sleep, those endothelial cells also take some rest. And in the morning when we wake up and we blink and we sort of get about our day, they wake up as well and help allow the cornea to return to its normal thickness. It turns out we're born with one set of these cells called endothelium. And as we age, these cells age as well. They do not regenerate. In Fuchs, effectively, there's a degeneration or a loss in the quality of these cells. Effectively, they age as well. And for many patients, since we're born with one set, they decrease in the quantity of healthy cells available. And for many, they're still fine. Maybe their vision's a little bit foggy in the morning, but generally as the day goes on, things clear up pretty quickly. However, Fuchs dystrophy is a condition where these cells effectively have accelerated their aging. And those cells that wake up in the morning have trouble waking up, and so the cornea that can get swollen continues to stay swollen, and over time can actually get more swollen. Once upon a time, the treatment for Fuchs was to replace all the layers of the book. Effectively, we would use something similar to a cookie cutter, remove the central portion of the cornea, take someone who had passed away but generously donated their organs, and used a similar cookie cutter to remove a healthy layer of section of cornea and implant it into the patient who had the disease. As you can imagine, that seemed to be the best option that we had at the time, but if we just had one layer that was defective, we were replacing all the layers of the book, and that necessarily wasn't the most effective. Over the last 10 years, there has been an evolution in the technique, and now we are able to selectively remove the back cover or the endothelium of a patient who has Fuchs dystrophy and replace it with another patient's endothelium and a thin layer of underlying tissue to effectively do a one-for-one substitution. So that means that the rest of the cornea, all the pages in the book and the top cover of the patient remain in place. This is important because with any type of transplant, specifically a corneal transplant, there's a risk for rejection. And we don't want the body to fight tissue that it thinks doesn't belong there. So as it turns out, if we do a selective replacement of just the back cover, we can actually decrease the risks of rejection. This procedure in and of itself is also performed as an outpatient procedure. Much like cataract surgery, you can have an IV and some sedation to keep you relaxed and awake, or we may elect to do the procedure under general anesthesia so that you don't have to worry about moving during the procedure. During the procedure, we actually will remove that unhealthy endothelium and take it out of the eye and basically implant the new tissue in place and keep it in position so that it fixates itself to the rest of the cornea. In order for us to do that, we actually strategically use an air bubble to fill the inside of the eye with air so that that new tissue can place itself comfortably against the rest of the cornea. In order for this to work effectively, we have to treat your eye like a leveler, which means that the position has to be adjusted so that your nose is pointed to the ceiling. And the benefit of having that position is that the air bubble remains directly underneath the tissue that we have implanted. This procedure in and of itself takes about 45 minutes to perform. In patients who have had multiple eye procedures before for either retinal problems or glaucoma problems, there may be scar tissue that requires further cleaning up and extends the duration of the surgery. After the surgery, the patient is kept in the recovery area in that nose up position flat for approximately an hour before being discharged home. Patients are sent home and asked to maintain that nose up positioning as much as possible for the following 24 hours. After that, you return back to the office for a post-op examination. Typically, with the surgery done on a Wednesday, you'd be back into the office on a Thursday, and we would evaluate how well that tissue is positioned and how well that it's functioning. As you can imagine, this newly transplanted tissue needs some time to wake up and adjust, and the recovery from this surgery takes approximately 4 to 6 weeks. Obviously, in some cases, things are recovering faster, and in other cases where there may be underlying other eye issues, the recovery may take longer. The risks for the surgery include the risks really with any eye surgery, including infection and bleeding. Specifically, we must consider the risks of rejection, in which case we may have to repeat the surgery itself and implant another tissue. And further consideration is that if that tissue were to not position properly, we may have to implant or inject another air bubble in order to help position the tissue. The good news is that air bubble technique can be done in the office rather than going back to the operating room, though in certain cases we may choose to do it in the controlled environment of the operating room. With this procedure, we anticipate that the corneal edema over time, the swelling of the cornea, will improve, and we hope that that would help improve the patient's vision. Of course, if there are other underlying issues such as retinal disease or glaucoma, that may impact the vision, but nonetheless, it's a good option that we can now present to our patients. I look forward to having a discussion with you for specifically how your disease manifests and what the options are for surgery and what we can expect after surgery. Thank you for your attention.